Okay, so that's the first disease you have to screen for, MASLD. Now I'm going to focus on alcohol-associated liver disease. And here we'll, just to set the stage for talking about at-risk alcohol use, just to remind you that a standard drink is equivalent to 14 grams of ethanol. So you have to know kind of the percent in the drink that you are talking to the patient about. There's different kinds of beer. Wine is different from hard liquor. But in general, usually we're talking about one beer, 4 or 5 ounces of wine, or 1.5 ounces of hard liquor. Now, why do we have to screen for alcohol use? It's because this use is on the rise in the United States, and it's increasing across really all the demographics. So shown here is data from the National Epidemiological Survey on Alcohol and Related Conditions. They did a survey in 2001, 2002, and then repeated it a decade later. And what you can see is that across the board, there's been increases in terms of the proportion of individuals who are reporting. These are meeting a definition of alcohol use disorder. So these are not just people who use alcohol, but actually meet the criteria for alcohol use disorder. And the really striking things is that there's been really the most rapid rises among women and in those that are of young age, under the age of 30. That's a demographic in which I think there's the most concern about the rise in alcohol use disorder. And just to give you a sense of that young age group and how important it is, these are data that are looking at alcohol-related cirrhosis and alcohol-related liver disease. And what this is looking at is the average annual percent change from 2009 to 2016. And the group that had the greatest rise in terms of alcohol-related liver disease and cirrhosis was, again, that group that's 25 to 34. So we need to screen because it's there, and if you don't ask, you won't know. And then the other thing, just to sort of build on the information I gave you around MASLD, is that we now know that alcohol and metabolic risks are often present in the same patient, that they have metabolic risks, they're overweight, they have dyslipidemia, they have diabetes, and they're drinking alcohol at harmful levels. And this is just one study that shows that leads to an exponential risk in their liver-related complications when you have both of these risk factors present. So we need to both screen for MASLD, and we also need to be screening for alcohol. And not to forget that when you see steatosis, that steatosis can be due from alcohol as well as can be from metabolic risks. So how do you do alcohol screening? Well, it's recommended by the U.S. Preventive Services Task Force that you actually screen. And the best approach is just to screen everybody in your clinic, so it sort of happens to everyone. There's no singling out of anyone in particular, and then you won't miss anyone. And you can use the AUDIT-C. That's the questionnaire shown on the right. It's 3 questions that the patients ask, so it's very fast. And if you have an individual who is a female and who has a score of 3 or higher, or a male who has a score of 4 or higher, that's considered a positive AUDIT-C. So the screening test is positive, and you should then go on to get a much more detailed alcohol history. Now, some people feel that that's even too much to do in a busy clinic. So there's also nice data that shows that if you ask one question, that it also has pretty good positive predictive value in terms of identifying individuals with at-risk alcohol use that would need a more detailed evaluation of their alcohol history. And that one question is, how many times in the past year have you had, for a woman, 4, or for a man, 5, or more drinks in a day? So if any time in the past year that's happened once, that individual also is at risk and should have a much more detailed alcohol history taken. So what is considered to be at-risk drinking? Well, for individuals who have underlying liver disease, any alcohol. So that's the first thing. So on the box on the right there is my kind of take-home message. If I have a patient who already I know has a liver disease, when they ask how much alcohol is safe, the answer is there is no safe level. You should not drink alcohol. But for individuals who don't have liver disease, what we know is that it's related to both the amount you drink and for how long. And so the drinking levels, it's considered moderate drinking as if a woman has 1 drink per day or 7 drinks per week. Men, it's 2 drinks per day or 14 per week. Anything above that or binge drinking is considered at-risk drinking, harmful levels of drinking, heavy drinking. They're all terms that are used to really reflect somebody who's got a harmful pattern of alcohol use. So anyone who binge drinks, anybody who's got heavy use, which is above that moderate, is somebody that really should be strongly counseled around their alcohol use, because these are the individuals that are going to present with alcohol-related liver complications. Now, I'll just mention that you can also use biomarkers to look for alcohol use. I use these in my practice, but I use them primarily in patients in whom we've come to understand that they have alcohol use disorder and they have alcohol-associated liver disease, and we're working towards sobriety. And I use it as a way to keep us open about that, how that's going, by measuring a biomarker to see if they are actually using alcohol. Now, I don't do it without telling them, because I want them to know that I'm using it as a tool to have conversations and as a way for me to be helping them in their journey towards sobriety, but to know that you can use them. PEth, or phosphatidyl ethanol, is the one that I use the most. It's a blood test and it reflects alcohol use over a 3 to 4 week period. So that's one that I tend to use the most often, but you can also use ETG or ESG, which are urine tests that reflect very recent drinking. What I would say, if you're going to use these biomarkers, is to do them in concert with the patient, knowing that you're going to be measuring them, have a transparent policy around why you're doing them and how you're going to use that information. It's particularly important for individuals who also, because they're alcohol-associated liver disease, are being considered for liver transplant, and that's probably the scenario in which we see their use the most often. And that's where having transparent policies around what you're going to do with a positive result is important. Okay, and then I think the other aspect is, if you make a diagnosis of alcohol use disorder, is to know what to offer patients. So the first is, the recommendation is to do a brief intervention, meaning you try to identify the triggers for them with respect to their alcohol use, try to understand the things that are motivating them towards sobriety or abstinence, make referrals for both inpatient and outpatient rehabilitation or alcohol cessation programs, and be comfortable using medications. And I just want to take a second to highlight the medications that are approved for use in patients who have alcohol use disorder. Naltrexone, acamprosate are the 2 that we probably use the most. I think disulfiram is not one that I recommend using. And then there are some non-FDA approved but frequently used drugs like gabapentin that also can be considered. But if we are to support our patients, especially our patients who have liver disease and alcohol use disorder, we need to get comfortable in terms of thinking about using medications to help them with craving.